In this video, I'll talk about how to approach a case of vision problems in the long clinical consultation of the MRCP PACES exam. If you're just beginning your preparation and you're unaware of how to take a history, you can watch the history taking video available on the channel. And if you're just starting your preparation, you can watch the beginner's guide video to get an idea about the exam format and the marking scheme. Okay, so let's begin with the vision problems. Before we get into the history, let's talk about how to prepare outside while we're given 5 minutes to prepare. You'll be given a scenario, read it twice at least. And on the page given outside, you're allowed to take it inside, write down the patient's name and age in case you forget about it. Write down the setting and your role. That means whether you're a junior grade doctor or if you're present in the ward or the clinic or the emergency. Your role isn't as necessary, but the setting is, because while you're introducing yourself, you need to mention whether you're present in the ward or the clinic. Next thing, the presentation and the duration of the presenting complaint. The duration is necessary because it can tell us about the onset and the differentials we need to think about. I'll talk about it in detail when we get to the history. Write down driving. This is very important in the case of vision problem. So the reason why this is really important is because it can affect your clinical judgment as well as patient welfare skill. Let's suppose you forget to mention and you forget to address the driving part. You do not tell the patient to inform the DVLA and stop driving. It can affect your welfare score. So this is one of the most important skills because it has a very narrow margin to pass. You only have 4 marks to lose the whole exam. Let's suppose in a station there are two examiners who are independently marking you, and both of them give you an unsatisfactory score. That means you lose 4 marks. It will just take one more mark and one more station to get you to fail the exam, even if you've performed well in the rest of the skills in the rest of the exam. So do not forget about driving. Along with driving, write down the job and impact, because vision changes can have a drastic psychosocial impact on the patient. It needs to be explored, although not in much detail, as this is not a communication station. Just one line asking about how's this symptom, how is this change affecting your life and your job, and offer a one line solution involving the relevant specialty in it. The next thing is on the bottom right corner, you can write down the things you'd like to examine. For example, the visual acuity and fundus in this case. Neurological examination can be done or can be omitted depending upon what the case is, but you can write it down so you don't forget about it. Okay, so these are the questions that you need to ask while you're starting your history taking. After the introduction, ask, what brings them to the clinic, or I've gotten a note from your GP saying that you've been having trouble with your vision. Can you tell me more about it? The open-ended question is preferred. All right, so in the scenario, they might give you vision problem. It can be as vague as that, or they can be very specific, saying it is double vision or blurring of vision. All right, so you need to ask about, is this the first time you're experiencing anything like this? Asking this question rules out whether the problem is intermittent in nature. Has it ever happened before? But when you're asking this, you need to think about multiple sclerosis because it is, spaced out in that over a period of time with a period of wellness in between. So each question you ask, you need to know the reason behind it. Just don't just ask questions for the sake of it. Each question has a meaning behind it. Next things, then the next question should be: was it all of a sudden or was it gradual? So in case of a general rule of thumb is if a complaint is sudden, the onset is acute, think about vascular causes. If the onset is over a period of days to weeks, think about infectious or inflammatory causes. And if it's long term or chronic, think about both inflammatory and malignant causes. So, likewise, in this case, you'll ask about the onset. Next thing is ask the patient, what do you exactly mean by a vision problem, or elaborate on what you mean by blurring or double vision. So what we're trying to establish is what exactly the problem is. So it can be blurring, it can be an eyesight problem, maybe near vision or far vision, could be total blindness, flashes, floaters, or double vision. Ask about, is it one eye or both eyes. Ask about pain, whether it is painful or painless. Other things that you need to rule out are, is there any glare or halos around lights? or if any one specific part of your vision is affected or all of it. This is a visual field loss. What we're trying to rule out here is if the central vision is affected, maybe the patient is having difficulty in reading newspapers or books. Think about causes such as cataracts, optic atrophy, macular edema, macular degeneration. These affect the central vision. If the peripheral vision is affected, let's suppose the vision is narrowed like a tunnel vision, think about retinitis pigmentosa. If just the sides, for example, the temporal sides of both eyes is affected, think about bitemporal hemianopia. Okay, so after these initial questions, you can get an idea of where the history is headed towards. And then you need to rule out some specific questions about that particular condition or the differential you have in mind. And then ask a general review of systems, and then the impact, driving and functional status. How is it affecting their daily life? Let's suppose a patient is a writer. He works at let's suppose, maybe a publishing company. He's a writer. So he's unable to see and it's affecting his job. What we need to do is, express empathy. Say, I'm sorry to hear that. I'll try my best to help you out. You can involve an occupational therapist, and you can mention that I can write you a medical note that you can show at your occupational health department at your workplace. So this is all we can do because the relevant specialties will then cover their domain. They can offer solutions such as maybe a text to speech option. Maybe they don't have to look at a screen and type it out. They can just use a voice recorder. But these are not something that we need to think about. We just need to offer a medical note and involve the occupational therapist. The occupational therapist might provide the patient with some walking aids or a white walking stick if he's legally blind or totally blind. So this is what the occupational therapist would do. Next thing to keep in mind is the past medical history or any underlying risk factors. For example, we know that diabetes can lead to diabetic retinopathy, and conditions such as macular edema and age related macular degeneration, and such. Also, cataracts, hypertension, and medications such as ethambutol or HCQ. Okay, let's talk about each specific complaint in detail now. Blurring of vision. The history taking pattern will remain the same. All these questions are needed to be asked, but you can be a bit more specific. So, do ask about whether this problem is getting worse with time, better, or is it the same? You're asking about the progression. Ask about associated symptoms like we discussed: pain, halos, flashes, floaters, or double vision. Ask about previous hospitalization or surgeries, including eye surgery. So this is basically the same pattern that you need to ask. While you're examining, start with the visual acuity and make sure that you test each eye at one time with the other eye closed. Visual acuity can be checked with the Snellen's chart or by finger counting. Next, check the pupils. They're reactive or not, and RAPD. You need to check the visual fields and do a fundoscopy. A very detailed or professional technique is not required. Just you should be aware of the basics, how to command the patient, direct the patient for a fundoscopy, knowing the basics, you need to turn the lights off, how to hold an ophthalmoscope, and how to perform it, and just basic details about looking at the optic disc, the macula, vessels. So, blurring of vision, what you need to think about is whether if it's gradual or is it sudden, and whether it's painless or painless, painful or painless. In case of painful sudden blurring of vision, think about optic neuritis, glaucoma, and uveitis. So, if it's optic neuritis, you can think about multiple sclerosis. It could be the first episode or it could be a recurrence. In case of gradual blurring of vision, think about cataract, diabetic retinopathy, and age-related macular degeneration. If it's temporary, think about TIA. If it's a painless sudden blurring of vision, think about amaurosis fugax, central retinal artery occlusion, and central retinal vein occlusion. These are some differentials that you need to keep in mind. In terms of the exam, the important ones that you need to know are optic neuritis, diabetic retinopathy, and TIA. Next, double vision. Now, this varies a bit from the conventional vision history. We need to ask about establish whether it's monocular or binocular. Monocular would mean that if the patient closes one eye, it would still persist, and binocular means on covering one eye, it's relieved. Yeah, and he's able the double vision is gone. So it might seem a bit confusing, but you need to memorize this. Secondly, ask if the double vision is just while looking at the sides, or looking up and down, or all around and throughout the day. um, each of this double vision has a different differential, and we'll talk about it. Ask about whether it remains throughout the day, or at any particular time of the day. This we're trying to rule out whether it's myasthenia. Third thing is, if you think that the history is pointing towards myasthenia, you need to ask some specific questions about it. For example, any tiredness, and is the tiredness worse in the evenings as the day goes on? Ask about ptosis by asking about any drooping of eyelids. Then, other differential for diplopia would be thyroid disease. You need to ask about systemic questions, ruling out thyroid conditions such as weight changes, appetite changes, bowel habits, difficulty adjusting to temperatures, swelling on the neck, and such. All right, so the examination, rest of the examination would be the same as we've discussed before this. Specifically for double vision, while you're doing the HF movement of the eyes, looking for any cranial nerve palsies, ask them if they have experiencing any double vision, and observe whether it's horizontal or vertical. Um, if the history was suggestive of myasthenia, you can check the fatigability of the proximal muscles. Um, Check the power and the strength of the upper arms, and then do a fatigability test. You need to ask the patient to wing their arm like a chicken beating manner, a chicken wing beating manner, and do it along with the patient so they don't feel awkward. So they'll be flexing their arms repeatedly for a few seconds, and then check the power again, and then compare it on both sides. If there is fatigability, the working arm, the one that was flexing, would be weaker as opposed to the other arm. You can watch some videos to see how to check for fatigability in upper limbs. Then, otherwise, if the patient has history suggestive of thyroid disorders, you can do a thyroid examination. So, talking about the differentials here, cranial nerve palsies 3, 4, and 6, that will be evident once you do the H shift movement on the examination. Myasthenia gravis, if the symptoms are worse in the evenings with other factors such as muscle weakness or drooping of eyelids. Thyroid eye disease, that also will be evident in the history and examination. And you can think about brainstem lesions, again, will be evident while you're doing the cranial nerve examination. Pain and redness. Although most of the causes presenting with pain and redness of the eye are purely ophthalmological, but we need to keep a couple of those in mind that can present as a part of other systemic conditions that are relevant to our exam. So, starting with the history, ask if it's painful or not, and if it is, ask about whether there is any discharge. Talk about vision changes and the progression. Some specific questions you need to ask about are: was there any trauma, or if they use any lens, any contact lenses? Then ask about any fever or headaches. In the examination, you'll be carefully looking at the lids for any swelling, redness, looking at the conjunctiva and the cornea. You need to check the pupils in every case. In this case, the pupil reaction will tell us whether the uvea is involved. So, if there is meiosis, that means pupillary constriction, think about uveitis. So, among the differentials which are given here, uh, what we're concerned with is scleritis, episcleritis, and uveitis. Because scleritis and episcleritis can present with RA and SLE, and uveitis, you can think about the triad of reactive arthritis. So, keep these things in mind. Flashes and floaters, you can ask about whether they're new onset or whether they're chronic, and if they feel as if a curtain is falling over their eye. This specific symptom is indicative of retinal detachment. So keep that in mind. You can again ask about whether their central vision or peripheral vision is affected. The examination remains the same in this case, but the differentials you need to keep in mind when the patient mentions any flashes or floaters are retinal detachment, retinal tears, and if the patient is diabetic, think about vitreous hemorrhage. It can Flashes and floaters can also occur with cataracts. So these are a few differentials that you need to offer to the examiner if the patient mentions these. So revising the examination, checking the visual acuity first, each eye at one time, using a Snellen's chart preferably. It will be available there. If not, then you can do finger counting. If the patient is unable to see at all, you need to omit the following examination of the ocular movements and visual fields. Skip that if the patient is unable to see anything. Otherwise, you're going to do the whole scheme. For fundoscopy, you should be able to differentiate between dot and blot, hemorrhages, exudates, cotton wool spots, and the macula. You can look up images online for practice. And visual fields where applicable. For example, if the patient mentions bitemporal hemianopia, maybe bumping into things, getting into accidents, you need to check the pupils and eye movements. If the patient is diabetic or hypertensive, always offer to check the blood pressure, a urine dipstick for glycosuria, and offer the sensory examination of the lower limbs if the patient has diabetes. And in cases of diplopia, apart from the general examination scheme, look for ptosis and any signs evident of thyroid conditions, proptosis, lid retraction. You need to do eye movements, the H-shape movement, and ask where the diplopia is worse. And for myasthenia, check the fatigability. And for multiple sclerosis, you need to see internuclear ophthalmoplegia. So that means there's ipsilateral failure of adduction and contralateral nystagmus. So in one eye, they'll be unable to adduct, ADD, adduct, and the other eye will be showing nystagmus, but the convergence would be fine. So even though the patient is unable to adduct his eye, while convergence will remain intact in case of internuclear ophthalmoplegia. So journal exam includes thyroid signs and fatigability test and cranial nerve evaluation. This is just a flowchart of how to proceed with the differentials. Let's suppose while you're preparing outside, they mentioned there is an acute onset of vision change. Think about temporal arteritis, optic neuritis if it's painful. If it's painless and transient, think about TIA or amaurosis fugax. And if it's sustained, think about retinal detachment or CRAO, CRVO. So these are acute conditions, painful and painless. If it's chronic, think about whether the central vision is affected or the peripheral one. For central, think about optic atrophy, cataract, macular edema, macular degeneration. If the periphery is affected, night vision is affected, or if it's tunnel vision, think about retinitis pigmentosa. And for the bitemporal, think about pituitary adenomas. One thing more about retinitis pigmentosa is, nyctalopia is the main symptom, tunnel vision, and then in the history, you need to ask about the associated syndromes with it. That means Refsum's, Usher's, Kay and Sire syndrome. So for Usher and Refsum, ask about hearing loss. For Refsum, do ask about if there's any problem with their gait, walking or balance. And for the examination, you will check cerebellar signs. And for Kay and Sire, there's cardiac symptoms. Ask about any palpitations, racing or pacing of the heart, breathlessness, and such. And offer a cardiac examination as well. So, in cases of retinitis pigmentosa, be very careful to rule these out in the history and offer the examination for all these things. Okay, so you can take a screenshot of this. This basically is in a nutshell the whole presentation today. If it's just diplopia of one eye, think about cataract. If it's horizontal diplopia on the sides, think about sixth nerve palsy. And if it's vertical, think about fourth nerve palsy. Third nerve palsy has a typical down and out eye with ptosis and a dilated pupil. Myasthenia would have diplopia worse in the evenings and ptosis worsening throughout the day. For thyroid ophthalmopathy, think about bilateral involvement, proptosis, and the similar complaints can present in an orbital mass as well. And if there are neurological signs such as hemiparesis ataxia, think about brainstem stroke or any SOL. This is just a mnemonic for causes of optic atrophy. Important ones in this case would be optic neuritis. For damaged, this is the mnemonic for causes of cataracts. The important ones that we need to keep in mind are diabetes, elderly people, myotonic dystrophy, and steroids. 4Fs are the symptoms for retinal detachment, flashes and floaters. field loss, that means a curtain effect, and falling acuity, that means sudden visual loss. So that's about it. Thank you for listening. If you need to go follow the Instagram page for Paces Guide. I have a compilation of examination checklists for LCC, covering almost all important and common cases. So you can go through them. And if you want one-on-one coaching for LCC and communication, you can send me a DM there. um, After the session is done, for these one-on-one coaching sessions, I offer a personalized feedback based on the RCP criteria. For candidates who are going to appear in the exam soon, in the next month or so, they can send me a DM. They can register themselves for a mock examination, simulating the real exam with two LCCs, two communication, and four short stations. After the mock exam is done, a feedback will be sent to them. So if you're interested, send me a DM. If there's any other symptom that you're having difficulty with, please leave a comment. I'll try to cover palpitations next. Thank you.